Okay, my next presentation, the how to choose appropriate polyp removal technique, EMR or ESD or polypectomy. Yes. Not sure why. First of all, I'd like to talk about the indication for polypectomy, EMR, and ESD. The indication for the endoscopic treatment strategy could be based on tumor size and histology. And first of all, how to treat CSI-serrated lesions. The indication for SSL, maybe in the Western countries, we know we should resect all SSL despite of the tumor size. And this paper from Dr. Murakami, Juntendo University, they reported the distinct endoscopic characteristics of SSL and SSL with dysplasia. They reported the double elevation or some depressed component, a tumor nodule, redness, depression, and type 3, 4, 5 pit, the feature of dysplasia. And how to treat SSL? Still, there is no consensus in Japan. But for my personal opinion, even for SSL without dysplasia, we should resect the lesion more than 1 centimeter in diameter. And of course, as Dr. Murakami's paper, when the SSL showed the nodule, redness, depression, type 3, 4, 5 pit, there is some possibility of dysplasia of cancer. So those lesions should be resected by endoscopy or surgery, depending on their estimation depths. And apart from SSL, some patients had lots of SSL and large SSL, so-called serrated polyposis. They have high risk of carcinoma, so they should be followed annually. And as for the long-term prognosis of SSL, still little is known. But from the several papers, the overall incidence of carcinoma in SSL is relatively low compared to conventional tubular adenoma. And how to treat SSL? It's called snare polypectomy enough for the SSL. There are several papers. This is from Dr. Ito, the resection depths and layer of cold snare polypectomy versus endoscopic mucosal resection using injection and cut using electrocautery units. They reported the depth of submucosal layer could be shallow by cold snare polypectomy compared to hot snare EMR. And as you know, the muscularis mucosa is difficult to cut by cold snare polypectomy. And the complete resection rate is statistically lower in the cold snare polypectomy compared to EMR. And importantly, vertical margin positive or unknown rate is much higher in the cold snare polypectomy group. So it is really important, don't perform CSP for the high-grade dysplasia or carcinoma. How about this lesion? Small one. This is a case at our National Cancer Center. Red polyp. And some, if you look carefully, some stretching fold. Could you observe? And in the NBI, there are difference. The top of this small tiny polyp, some vessel pattern, brownish, and the right side, left side different. And the lower part could be the normal mucosa. So this could be some SMT-like elevation and some fold stretching, if you look carefully. But unfortunately, the doctor didn't perform any chromoscopy and performed a cold snare polypectomy for this lesion, and histology was well-differentiated adenocarcinoma. And using the Desmin stain, desmoplastic reaction was observed around the tumor, and Desmin stain showed no musculus mucosa, and desmoplastic reaction was diagnosed caused by cancer invasion. So no more cold snare polypectomy for cancer, and image-enhanced endoscopy with chromo is really important. So keep this lesion in mind, please. Next topic, how to choose EMR or ESD for large LST lesions. This is the paper from Endoscopy. Yamada, our colleague, the first author. And LST non-granular type, about 45% SM penetration could be multifocal. So these lesions should be resected en bloc. But even for LST granular type, 16% SM penetration could be multifocal outside the large nodule or depressed component. So not only LST non-granular, but also LST granular could be resected en bloc. And more importantly, the pit pattern show the highest diagnostic accuracy. However, the sensitivity of pit pattern for LST-NG was 71%, and sensitivity of pit pattern for LST granular type or just 52% because of the protruded morphology. Specificity pit pattern is really high, 98% for both regions. So keep in mind to understand the limitation of pit pattern and positive predictive value. Specificity of pit pattern is quite high, more than 98%. But negative predictive value, the sensitivity of pit pattern is a little bit lower, 70% for LST-NG and just 50% in LST granular. And therefore, our indication for ESD is the LST non-granular type more than 2 or 3 centimeters, LST granular type, nodal mixed type more than 3 or 4 centimeters. But rectal net could be treated by EMR-C or ESMRL. And for the adenoma, the small lesion less than 10 mm cold snare polypectomy could. How about this LST granular type in ascending column? And what kind of lesion could be treated by piecemeal EMR? So we evaluate the SM invasion rate according to the tumor size, large nodule, or depressed component. And from this analysis, when the lesion has no large nodule, no depressed component, and tumor size less than 3 centimeters in diameter, the incidence of SM invasion was just 3%. So this kind of lesion could be treated by EMR effectively. Yes. How to perform the effective EMR? So for the same lesion, the focusing on the nodule, the JNET classification is regular vessel, regular surface, JNET 2A, suggesting low-grade intermucosal neoplasia. And after endocardinal display, pit pattern type 4, And after submucosal injection, lifting very well. And this region, no large nodule, no depressed compound. The size is around 3 centimeter or less. So the incidence of SM invasion, less than 3%, almost 3%. And another important point is adequate submucosal injection is essential. And don't perform injection multiple location. The best thing is only 1 or 2 point injection. If you inject from various sides, not only the tumor, but also the surrounding mucosa will be raised up. So en bloc resection become really challenging. So just 1 or 2 injection only raise the tumor itself. And en bloc resection by outpatient clinic possible, the histology revealed tubular adenoma curative resection was achieved, no recurrence. And for the basic technology of EMR, no biopsy, especially for this kind of flat region. In this case, we could perform en bloc EMR by day surgery, but if you take 1 or 2 biopsy before EMR, this kind of excellent EMR would be really challenging. The final topic, how to perform ESD safely. Conventional ESD technique using the bipolar
colorectal ESD using bipolar knife, the jet beam knife, and
published
IT-knife
in
nano.
Video GIE.
This video is partially funded by the National Cancer Center Research and Development Fund.
Because of the time limitation, so please refer this Video GIE in the internet. And I also prepared another ESD movie. How about this? In the ascending column, the half circumferential LST non-granular and the center depressed component. After endocarmine dye, you could see the tumor margin depressed component. So this is LSTNG, pseudo-depressed type. And also in the center, there are a little bit deeper depressed component. But magnified NBI showed the most part of this region, regular, a little bit irregular vessel, irregular surface, but JNet type 2B. But pit pattern, 3L, 3S, 3L, 3S in most part. Only the depthless component, the pit type 5 low irregular pit and small erosion could be observed. Okay, ladies and gentlemen, please answer. How about this region? Please vote.
So, Professor Yutaka, to be honest, I do the ESD for this kind of lesion yesterday.
Oh,
the
really?
Same one. Yes, but I fell. It's in the middle of the lesion is the inverted, so I stopped the ESD procedure. So, to be honest, it's the same. I choose the C.
So, could you observe the cancer invasion during the ESD procedure?
Yes, yes. In the middle of the lesion, in the center of the lesion is the invasive plane. I cannot see the plane to cut it off. So I try cut it off, and then I feel that I am cutting into the tumor. So I stop it. So better to go for surgery.
Yeah. Okay, the more than half diagnosed SM2. Okay, please go to next slide. And for this case, we also perform end brain, end side. After double stain, crystal white staining and methylene blue, this is a really nice image of the center depressed component. Next slide. Yes. endoscopic diagnosis of end brain, neoplastic, non-invasive. And this is the day of ESD. Using the short type ST food, we perform rectal flexion, but at this moment, maybe this was the 2 weeks after the endoscopic diagnosis. So I observed some deeper depressed component. So at this time, I really thinking to stop ESD because even this conventional image, this could be the submucosal deeply invasive cancer, as Supakij said. But finally, I continue ESD. Oh, sorry, ESD. How about the movie? Okay. Rectal flex position, injection. It's important, don't perform circumferential resection in the colorectal ESD. So I'm performing the partial marginal resection and then directly move to the submucosal dissection. And after the submucosal layer expanded, I prefer to use IT nano. And I always use this short type ST food. Oh, I'm really happy Dr. Kikuchi also like this short type ST food. And probably nobody know about this. So conventional ST food was developed by Professor Yamamoto, GT University, but this short type ST food. So I asked Fujifilm company to make this one. So this is developed by me and Fujifilm. But unfortunately, no incentive for me for this short type ST food. But it's good for colorectal ESD. Unfortunately, despite of the tumor deep depressed component, the submucosal lifting was really nice. And after completing the submucosal dissection of the rectal flex position, now I'm starting the marginal dissection of the anal side using the straightforward view. And after marginal dissection, using the water jet function through this same V-knife. It's really important to start the submucosal dissection immediately after partial marginal dissection. And also, this short type ST food is really nice for entering into the submucosal layer effectively. And then submucosal dissection using the IT knife, nano. Of course, as Supakij mentioned, from the endoscopic finding, if during the submucosal dissection, if we encounter the deep submucosal invasion or severe fibrosis, the no space between the muscle layer and the submucosal layer, we should stop the ESD procedure. But finally, fortunately, the en bloc dissection completed without any complications. And this is the resected specimen. This area could be the deep depressed component. This is a pathologic loop of the resected specimen. This is the deepest portion of the histology. The histologic diagnosis was well differentiated adenocarcinoma, and the muscularis mucosa invasion in the depressed component, but no submucosal invasion. and no lymphovascular invasion, and budding grade 1. So curative resection was achieved in this patient. So this lesion was really nice by the effective ESD. In the past, without the technique of ESD, even if we diagnose the interim causal SM superficial for this kind of large LSTNG lesion, we had no endoscopic treatment possibility, and laparoscopic surgery was done for this kind of lesion. Another similar case. This is the recent case. Okay, this is a tumor located in the cecum bottom. And tumor morphology also the LST non-granular, pseudo-depressed type. Relatively, we could observe some tumor thickness and relatively depressed component in the center. And some stretching folds. And of course, it's really important to use the non-traumatic catheter to observe the target area. And changing to NBI. This is NBI. And also this is the center depressed area, and magnification, irregular vessel pattern, irregular surface pattern. And this is a crystal white staining. This is tumor edge, and this is the center depressed component. And now there are some demarcated area after crystal white staining here. But pit pattern here, type 3L, 3S pit pattern. There, this demarcated area. And this is the most depressed component. The pit pattern 3S, 3L, and this area type 4. The endocytoscopic image. Oh, okay. Oh, so no Q&A slides, but Dr. Supakij, how do you diagnose this lesion?
I think it is non-invasive lesion.
Oh. Hmm.
Yes, so I think I will go on with the endoscopic resection, the ESD, for this kind of lesion after the detail that you gave it to me. So it's all of the detail is indicated is not non-invasive.
Yeah, but how about this the conventional white light image?
Yeah, with the conventional image that you provided, it seems like they have the invasive part in the middle, that they have the retraction in the center.
Okay, yeah. Oh, Supakij has like an eagle eye. Yes. As for me, also, I'm a little bit curious about some causal invasion in the conventional white image. But after the detailed pit pattern, so I thought there's some possibility of interim causal or SM1. And also, endocytoscopic image is also confirmed the interim causal neoplasia. So this is a recent case, so different from the previous one. We are using the cap, mask, goggle, and it's a really tough situation for us. How about in Thailand? You also do this kind of standard precaution during the endoscopic procedure?
Yes, we're doing it. During the high pandemics is on the April, so we stop the elective cases. We do only the emergency cases, and if we do it like this.
Now in this case, the lesion located in the cecum bottom, so we couldn't perform retroflex of the scope. So I first do the marginal resection of the and the submucosal dissection of the oral side in the straightforward view. And then in the straightforward view, after completing the marginal section of the distal end, so we are starting the partial marginal section of the anal side using the bipolar needle knife. And after resection, so we inject the glycerol solution through the same jet B knife. And when we visualize the thick vessel, it's really important to pre-coagulation. And now you could see the very nicely elevated submucosal layer. So we are dissecting the lower third portion of the submucosal layer. And this vessel is already pre-coagulated, so we could continue the section. And you could see the muscle layer here. So it's really important to dissect along with the muscle layer. Don't toward muscle layer. Now this is the similar to pocket creation method by Professor Yamamoto et al. But in the second bottom, so sometimes only using pocket creation method. So sometimes it's difficult to visualize the cutting line. So the traction method is really useful, even with pocket creation. Now the submucosal layer expand. The traction is really nice for the resected specimen. And using IT knife nano, we are performing submucosal dissection. And the ST food, short type ST food is really nice to enter SM layer. The combination use of short type ST food and Assoc clip traction is really for visualizing the cutting line. Even during the ESD, sometimes we ask the patient using surgical masks. And now the marginal resection of the lateral side also performing by IT knife nano. The marginal resection, left marginal resection by IT nano. The longitudinal cutting is really easy and effective by nano. And this is almost the final part of the dissection. We are already approaching to the oral side of the dissection area. And for the pocket creation method with only using needle type knife, sometimes the opening the pocket become difficult and the final portion of the dissection become difficult. But using the IT knife nano, so the opening the pocket or the final portion dissection is easy. Of course, considering the cost, it's better to use the only one device, but for considering the safety and the speed of the dissection, sometimes the two devices could be fine, because IT9 nano has a very strong power for the coagulation, so we rarely use the coagulosper during the colon ESD. And recently we performed the super high magnification even after endoscopic resection. Endocytoscopic imaging could be possible after ESD resection. In this case, pocket creation method with Assoc traction are really effective. And after resection, we put the resected specimen into the saline. And we could observe the pit pattern very clearly. So this imaging is almost the same as the stereomicroscopic image, and easier. And again, the histology was where to moderately differentiate adenocarcinoma, intramucosal, and the lymphovascular invasion was negative, bad in grade 1, and curative resection was achieved. Okay, the final topic is endoscopic resection for rectal net, neuroendocrine tumor. The indication for local resection of rectal net is mainly less than 1 centimeter and grade 1, net grade 1, and no lymphovascular invasion, and limited in the submucosal layer. And we reported several papers, the effectiveness of endoscopic submucosal resection using the ligation device. Well, this is small SMT, yellowish color, less than 1 centimeter, and after submucosal injection, and attach the ligation device and band it, and resect under this band. The other resection completed less than 3 minutes by day surgery. And this EMR technique is really nice, cheap, quick, like Yoshinoya Big Ball. Another one, also using the EMR technique, nicely resected, 3 minutes. Sometimes the patient refer to our National Cancer Center for conventional endoscopic mucosal resection was done, and the vertical margin was positive or unknown, and further treatment. In this case, in a previous clinic, conventional EMR was done, and the vertical margin was unknown. The histology showed the rectal net. So, first of all, I think I could again perform the ESMRL or EMR using CAP method could be possible. But unfortunately, the scar was much larger than expected. So I changed the strategy for emergent ESD by day surgery. We can do the day surgery, day ESD for this kind of lesion because the lesion located in the lower rectum, there's no risk of perforation. In this case, after marginal resection, and en bloc ESD could be possible. Okay, I think we have still enough time, so I will talk about the recent paper published from our colleague in the USA Cleveland Clinic. Now, at this moment, still there are debates between EMR or ESD for large colorectal LST, especially for LST granular type. And from our National Cancer Center, we published the paper. The invasive recurrences occurred after piecemeal EMR, the several cases. So we never, Japanese endoscopists never perform multi-piecemeal resection for large LST granular type. But until now, such kind of report only from Japan or Asian countries. And still the ESGE guideline recommend piecemeal EMR for LSD granular type, and ACE group in Australia, still they recommend multi-piecemeal resection even for the large LSD granular type. And they say never experience the invasive recurrence. This is recently published in Surgical Endoscopy, Dr. Need and Dr. Amit Bhatt from Cleveland Clinic. They compare, they conducted the retrospective cohort study and the recurrence after resection polyps with high-grade dysplasia, means intramucosal cancer in Japan. And in their long-term follow-up, malignant recurrence means invasive cancer recurrence or lymph node distant metastasis occur like this. They reported their study demonstrated that local recurrence with malignancy after endoscopic resection of LSTs with high-grade dysplasia is uncommon but clinically important phenomenon, which may be associated with piecemeal endoscopic resection. If piecemeal resection is to be attempted for the treatment of these polyps, close endoscopic follow-up is imperative. Alternatively, when expertise is available, en bloc resection technique such as ESD should be the goal. ESD and other en bloc resection technique can provide potentially curative resections, minimizing the risk of malignant recurrences. I think this kind of paper are reported not only from Japan, but also from Western countries is really important. We hope no more piecemeal EMR for the large LST granular type. So, ladies and gentlemen, let's summarize my second talk. Again, JNET2B suggesting high-grade cancer. Therefore, JNET2B without invasive pit pattern performed by crystal light staining is the indication for endoscopic resection. But for the JNET2B lesion, there are still some possibility of submucosal invasion. So please perform en bloc resection. And again, LST non-granular type and granular mixed nodular type should be resected by en bloc resections. It was reported the ESD showed the longer procedure time and higher complication rate. However, the recent advancement of ESD strategy and various traction methods makes ESD easier and much faster than the previous. So using this kind of the textbook, please learn more and more about JNET classification and pit pattern diagnosis, and please conduct the effective endoscopic resection. Learning from textbook, e-learning is still necessary. 10分間. Thank you very much.
Thank you. So, yes, so if the audience have the question, please typing in Q&A. So let's start. Thank you very much, Professor Saito. You show us the very good and very informative experience. Okay, so the first question is come from the audience. They're asking about the comparison between the TAN excision and then the ESD or for the lesion located in the lower rectum, do you have any data or any opinion for this kind of the technique? Transanal excision?
Transanal resection. Yeah. So there are some comparison reports, for example, but the comparison from professor in Italian surgeon. Data was a little bit old, so there, what kind of paper is a meta-analysis of the ESD and TEM procedure. They reported the TEM showed the higher R0 resection rate compared to ESD, but the recent ESD technique showed almost 100% R0 resection and block resection. So I believe the recent technology, ESD, showed the higher R0 resection rate to TEM. And also ESD is much less invasive compared to TEM. In addition, our high definition endoscopy could observe the tumor margin in detail, especially for the very flat region. I believe ESD showed a higher R0 resection rate. Actually, our old study to compare our ESD results and the transanal resection, was not a TEM, but transanal resection show. The ESD showed lower recurrence rate compared to transanal resections.
Yes. For this question, I agree with Professor Saito that as a surgeon, transanal excision is not easy actually, and then they have the limitation for the location of the lesion. In the deeper part, going upper part of the rectum or something like that, the transanal excision is almost impossible. And for the visible, I think the ESD procedure had more clear vision. I mean, the more clear for during this section. But actually, as you mentioned, that ESD procedure have a little bit difficult, and then they need the expertise to perform the ESD procedure, especially in the colon or the rectum. Even with the rectum, rectum is more easier than the colon, but still need expertise to perform the ESD procedure. I think that for the surgeon themselves, if they are familiar to do the TEM or do the transanal excision, if they can do that better than they do the ESD, it's okay. You can use the transanal excision or the TEM instead of the ESD procedure. But if you can do the ESD procedure, you can practice and then try to starting doing the ESD procedure. Maybe it's more benefit for the patient in terms of the outcome, and then in terms of the recovery period from the procedure, and also for the cost. I think cost of the TEM is more expensive than compared to the ESD by itself. And yes, so if you can starting the procedure, learn how to do that, maybe it's better for the patient and better for your economy also. So that is, in my opinion, for compare the TEM to the ESD, because I'm a colorectal surgeon. I previously do the transanal excision, and then now I 100% doing the endoscopies, and I compare it by ourselves. I think the ESD procedure is better compared to the transanal excision or the TEM. So please, that is our answer.
So important comments from the colorectal surgeon who know the both of ESD and the TEM.
Yes, thank you. Yes. So another question from the audience, they're asking about the energy mode for the coagulation during the ESD procedure to coagulate the thick vessel. What is your recommendation, Professor Yutaka?
So for the pre-coagulation of the thick vessel, I follow the Professor Toyonaga's setting, so-called 110. The 110 using the Bio 300D. And for the Bio 3, so the setting is a little bit different, but the principle is the same. The effect is very low and low wattage. It's a little bit similar to soft coagulation mode, but it's really effective.
So the same thing with the energy mode. Currently, Olympus launched out the energy device, the generator, the ESG 300 something, right?
Yeah.
So you have experience on this thing compared to the Vio?
Yeah, I used the ESG 300 several times. I think it's almost the same, very similar. So it depends on the endoscopy preference. Someone say the ESG 300, the coagulation effect is much more than the Bio 3.
I see.
So maybe we need to a little bit adjust the setting.
Yes. Okay. So okay, and then they asked one question from the audience. They're asking about the role for the diagnostic ESD. So what your suggestion?
Yes. Diagnostic ESD is a little bit difficult because it sometimes depends on the endoscopic diagnostic level. But in the past, so because we have no good technique for R0 resection, especially for the large lesion, so if we suspect some causal invasion, so we tend to send the patient to surgeon. So that's why, that means there are some over surgery cases increasing. But now, so of course, if we diagnose the lesion is invasive, especially outside the lower rectum, so we never perform diagnostic ESD. But the diagnostic accuracy is some low confidence. We could try the diagnostic ESD, but it should depend on the endoscopic skill and the possibility of R0 section without complication. Because if you try to dissect deeper and deeper for the suspicious some causal invasive cancer located in the proximal colon, there is the risk of perforation increase. So we should think about very carefully.
I see. So my question about the diagnosis for the lateral spreading tumor, the granulopathy. So which part of the lesion that you recommended to observe in detail? Because sometimes it's very difficult to see that which part of them is we should focusing on the detail to determine that this is the invasive or non-invasive. Do you have any suggestion for that?
Yes. So, as usual, the time is limited even for the observation. So I try to focus on the suspicious area, such as deadened area or depressed component or large nodule. So I only focus on the suspicious area and magnify the NBI and the pit pattern. But sometimes I ask our resident doctor to perform the diagnosis before EMR or ESD. They try to magnify all of the lesion, but it is not practical. So in the white light image or non-magnified NBI, we should focus on the target area and then focus on the target area with magnification. It's important.
Okay. So for the technical for the ESD, you mentioned that you're using the ST hood, right?
Short
type ST hood from the Fujifilm that is have the taper in the shape, but the tip of the hood is a little bit hard, right?
Yeah.
Compared to the soft type tip.
Yes.
So you have the problem with that so hard. I saw it, but I never tried because I'm afraid of the perforation or something when we traction. But I think that I try another company, short taper hood, too, because they made it for us, but it's not well, not completely yet. But I found that the taper was very useful, as you mentioned, and then yes, very good for the going into the submucosal tunnel.
Yes.
So you have the problem with the harder of the tip.
Yeah, sometimes when we do the retroflex in the proximal column, so sometimes we experience a mucosal tear. So of course we should a little bit careful for, but in the submucosal layer, if we just enter in the SM layer using short type ST fluid, I never experienced the perforation with the tip of short type ST fluid in the SM layer, or even in just above the muscle layer. But when you do the retroflex, maybe we should be a little bit careful. In a retroflex, if the tip hit the muscle layer of the ulcer bed, there are some risk of perforation.
Okay. And you mentioned that you use the traction device. Currently you use the Assoc clip, right? For the traction?
Yeah. In the proximal column, I prefer to use Assoc clip. But in the rectum or rectosigmoid, so considering the cost and the easiness, I always use the clip nylon traction. Clip nylon traction or dental floss traction. It's really useful. And maybe for the transanal resection, the surgeon think comfortable because of the traction device in the transanal resection TEM procedure. So recently, even for the rectal ESD, if you use the dental floss traction or clip nylon traction routinely, the traction is like surgeon's left hand. So ESD become easier.
Okay. So sorry, my connection was gone. It's just coming back.
Oh.
Yeah, sorry. Yes. So the next question is they're asking about the hybrid ESD. So what is your recommendation to use a hybrid ESD or the complete ESD? So what is your opinion?
Yeah. For my opinion, hybrid ESD could be the bridge for the beginner, ESD beginner, from conventional EMR to the ESD, complete ESD. Because our colleague, Dr. Sakamoto, also reported the clinical usefulness of hybrid ESD from our experience. And he reported the limitation of hybrid ESD, maybe the tumor size until 3 centimeter. The more than 3 centimeter, the hybrid ESD would result in piecemeal resections. But of course, the maybe first hurdle for the ESD beginner might be the complete submucosal dissection. So maybe for the ESD beginner, they can start from the relatively small region, 3 centimeter LST. And then for 3 centimeter LST, hybrid ESD could be possible. So, and step by step, if the beginner doctor think high confidence with hybrid ESD technique, and they can increase the dissection period. And finally, they can perform the complete ESD.
I see. Thank you. So my personal, I doing the hybrid ESD usually for the rectal net, the one that you show us on the last slide, that rectal net. I usually doing the hybrid ESD. to get the margin of the lesion, and sometimes is doing the complete ESD for that kind of the lesion. Yes, and they have another question. They're asking about the gravity to facilitate during the ESD procedure. You have some recommendation to how to do the patient changing the position. How could we do that?
Yeah, so patient position is really important in colorectal ESD. It's different from gastric or esophageal ESD. So in the gastric or esophageal ESD, we usually use the deep sedation, and because of the patient position, so patient position changing is usually not performed. Not only when in the stomach, the region located in the fornix. So sometimes the patient position of the right side down could be really nice. But in the colorectal ESD, the routine patient position changing is very effective. But if you do the colon ESD with under general anesthesia, maybe patient position changing is really tough. So when I perform the live demonstration in foreign countries, and they use the intubation, so sometimes patient position changing is challenging. It's possible, but we need to ask the anesthetist, and it will take the time to change the patient position. But in Japan, so we recently used the propofol sedation even for the colorectal ESD. But before we used the small amount of midazolam and pentagene for colorectal ESD with conscious sedation. In such situation, we can continue the ESD with talking with the patient, and we can ask patient to change position by themselves. In another, recently we use the propofol sometimes, especially because sometimes the resident doctor does the ESD procedure. So propofol sedation is nice for the patient. But even in such situation in Japan, the patient position changing is relatively easy because most Japanese patients are very thin. Very thin.
Yes, thank you. And another question I asking that you show us a lot of the endocytoscope. Can I ask you about the training of the future endoscopy of the how to differentiate the lesion? Do you think that we need the endocytoscope in the near future for to learning how to do the cytoendoscope in the near future instead of not instead of the chromoendoscopy with the magnification, but in what do you think? We should learn it or just wait and see, or what do you think?
To tell the truth, maybe you can wait and see. We are using the endocytoscope for mainly for the clinical research. But of course, the Dr. Professor Mori's group, Professor Kudo's group, reported the additional diagnostic accuracy using endocytoscopy is maybe 3% or 5% compared to the optical zoom magnification. But another point could be because our definition of invasive pattern is not only the irregularity of pit pattern, but also the demarcated area. For our invasive pattern diagnosis, maybe we think not only the very small point super high magnification, but the area by the moderate magnification could be good for the tumor depth diagnosis. But at this moment, we don't have the answer. And
Thank you.
Another point is endocytoscopic diagnosis is really good for the AI diagnosis, artificial intelligence, because the endocytoscopic diagnosis is 500 times magnification and contact image. Always the endocytoscopic image contact to the tumor surface, and focus of the area for the AI technology is always the same. That's the point. The endocytoscopic image is good for AI technology, and the end brain is now commercially available in Japan and in some foreign countries. So if you would like to use the AI end brain diagnosis, endocytoscopic image is good.
I see. So the last question is from the audience. They're asking about the training, how to do the ESD, just from the beginner. So what is your recommendation for someone want to starting the colorectal ESD? So what is your recommendation?
Yeah, so as mentioned by Dr. Kikuchi, hands-on using the isolated pig stomach. Pig stomach is really useful. So maybe to do the clinical case observation at the Chulalongkorn Hospital or National Cancer Center several times, and also to enjoy the hands-on using isolated pig model.
Okay. Thank you very much, Professor Yutaka Saito, for the wonderful presentation and then sharing the experience. And so, please, Professor Dr. Chainarong, Dr. Rapat, Dr. Som, please. I forgot her real name. Sorry.
Okay, thank you very much about Professor Kikuchi and Professor Saito. We enjoy your lecture very much, and I think our participants get more knowledge from your lecture. And there's a lot of questions also. It's a practical point. I hope we can use this in our practice. So we coming to the end of the conference today. I hope everyone enjoyed conference, and I would like to close the conference today. And we want to remind that there's another day of conference on 11th July. It's a half-day conference from 9 to 12. It's about the case discussion, so you can enjoy the. We will prepare the case to discuss, so you will enjoy how to make a decision to do that case and how to manage the case. I think it's very interesting. And finally, I want to close this conference today. Thank you very much for everyone. Thank you.
Thank you very much.
Thank you very much.
Thank you.
Thank you.
Thank you.
And for the participant, I want to remind that may I have yes. The rerun of the webinar today will announce in the ANBIIG Facebook. So please go to the Facebook application and click like to the ANBIIG page. So we will launch the link to see the rerun webinar today on that Facebook. And today our staff will send you the evaluation form. Please complete it and send back to us. We will appreciate that also. And the post test also. Please know that everyone who complete the pre-test and post-test can get certificate of this ANBIIG workshop. And next time is on 11 July. So the registration will be sent you to 1 hour before the meeting. Sorry.
1 hour.
1 hour after you complete the post-test. So do the post-test first. Okay. The certificate I already mentioned already. Okay. Thank you very much.
Thank you.
So thank you, Professor Daisuke and Professor Yutaka. And see you in 2 weeks too for the case sharing.
ありがとうございました、先生。
お疲れ様でした。
ありがとうございます。
See you in 2 weeks.
Thank you very much. ありがとう。
よろしくお願いします。Thank you very much, Dr. Supakij.
Thank you.